I'm getting the thumbs up. So I'm really sorry I can't be at the meeting in person due to the train strike. And I've heard that unfortunately Tim also has been struck down by the COVID virus. So we've had to resort to technology. And as I was saying to Tracy, we're much more used to virtual meetings now since the COVID pandemic. So some of you in the audience will have met me before at other previous annual meetings of the UK Wolfram Association. I'm a neuro-ophthalmologist by training. For the past 20 years, I have been doing research on various genetic eye diseases, including Wolfram syndrome. I run a clinic at Addenbrooke Hospital in Cambridge and also at Moorfields Eye Hospital in London. And my research is focused on a number of strands. We're very much focused on looking at the genetic basis of various eye diseases. And increasingly, we're focusing on better understanding how the optic nerve gets damaged and how we can develop better treatment to try and stop vision from getting worse and also potentially to improve the vision down the line. So in this presentation, I'm going to talk about how vision is lost in Wolfram syndrome. Tracy was telling me that there will be a number of new families who will be attending the meeting this year. So I thought I would go over some of the basics first, just to give you an idea about how complex vision can be and how challenging it can be to do clinical trials to prevent vision from getting lost. I'm also going to talk about the visual prognosis in Wolfram syndrome, and then mention some of the work that we're doing in Cambridge in the vision lab. So what about vision, right? This is what you see when you look at yourself in the mirror. You have your upper eyelid, you have your lower eyelid, and then you have the pupil, which is the aperture through which light is getting into the eye. And at the back of the eye, you have the retina, but in the front part, you have something called a crystalline lens. And the lens is very important because if you did not have a lens, the light that gets into the eye would be very diffuse. Whereas with the lens, it allows the image to be focused at the back of the eye, and that gives you a much better clarity in terms of your vision. And that's the reason why, as we grow older, we develop cataracts where the lens becomes more yellow and thicker, and very often it reaches a point where you need to have cataract surgery done. Otherwise, the vision is too blurred. At the back of the eye, you have this very transparent film called the retina. And the reason why the retina is very important is because it converts this light energy into an electrical signal. It is quite a complex process because there are many layers to the retina. There are many different types of cells to the retina. But in a sense, what it's doing is allowing the cells to absorb the energy from light, and then it transmits that to various cells, and then it produces this electrical signal. And the electrical signal is then channeled from the eye to the brain. And the layer which allows this to be done is a layer called the retinal ganglion cell layer. And these retinal ganglion cells are very important because they are the final port of exit from the eye. And these retinal ganglion cells are very long, and they have little outstretchings. And as it goes out at the back of the eye, the axons of these retinal ganglion cells combine and form the optic nerve. So when you're born, you have roughly around 1.2 million of these retinal ganglion cells. And as we grow older, we lose some of these retinal ganglion cells, but normally we keep sufficient number of them to have good vision well into our old age. So in effect, although the system is quite complicated, the eye is a very sensitive camera. It's the best camera that you can have. And once it produces electrical signal, it needs to send this to the brain because the brain is what allows you to perceive the image and to make sense of the image. And in between, you have a very complex network. And the optic nerve is a very key component to this because it allows the signal to be moved from the eye to the brain very quickly and very efficiently. It's a bit like a broadband cable. Without this, everything goes very slowly, and it's not very accurate information that gets to the brain. So I spend a lot of my time looking at the back of people's eyes. And when you look at the back of the eye, that's what you see. You see this golden yellow disc, and from the disc, you see these vessels emerging, these blood vessels, which allow blood to be supplied to the retina. And when you look at the optic disc, here is from someone who is completely healthy, does not have any eye problem. And you can see that the optic disc has a very healthy, very golden yellow color. And when there is disease, this changes. I've mentioned the retina already, but even the retina has different parts to it. And one part of the retina, which is very important in terms of vision, is the macula, because the macula is what gives you your central 6/6/20/20 vision. So if you have a problem with your macula or with your optic nerve, you lose your central vision. And in this example here, you can see that you're still able to see what's in the periphery, but you're not able to see straight on. And in this context here, it's very difficult because you can't make out people's face and people's reactions. So if you have optic nerve damage, this is a major problem in terms of visual perception. So in Wolfram syndrome, as a lot of you will know in the audience, optic nerve damage, optic atrophy, and visual loss is an important component of the clinical features that people develop. So here again, I'll show you a picture of the healthy optic nerve. And then as the optic nerve gets damaged over time, it becomes very pale, as you can see here. It becomes chalky white in color. And the reason for this is because these retinal ganglion cells have been damaged, and the axons from these retinal ganglion cells have been lost. Unfortunately, with Wolfram syndrome and with many of the genetic eye diseases, we do not yet have an effective treatment that will allow us to stop these retinal ganglion cells from getting lost and stop the optic nerve from getting damaged. And that's the reason why a number of groups worldwide, including here in the UK, are working very hard in terms of looking at better ways of preventing these retinal ganglion cells from being lost in the first place. Because even if you're able to stabilize vision, this will be a big advantage, because if you're able to intervene early enough, you might be able to maintain the vision at a reasonable level. This is the diagnostic criteria for Wolfram syndrome, which was put together by a consortium led by Tim Barrett. And I think in due course this will be updated, but nevertheless, the two main features of Wolfram syndrome is diabetes mellitus, which develops before the age of 16, and also optic atrophy. And you can see here that the optic atrophy is labeled as being present in about 80% of people who are affected. But I must say that in my personal experience, this is much higher, because now we have much better ways of looking at the optic nerve. And sometimes people can have very subtle involvement of the optic nerve, and they are not aware of any problem with their vision, but we know by doing the test that the optic nerve is starting to get affected. So I'm just going to briefly mention about the genetics of Wolfram syndrome, because this is relevant in terms of how the loss of vision progresses over time. So very briefly, because you probably have heard about this already before, either from your genetic counselors or from your physicians, but for most genes, we get two copies, one copy from mom and one copy from dad. And if you have a defective gene copy, and mom carries one copy and dad carries one copy, then there is a 25% chance that you get the bad copy from both mom and dad. And if that's the case, then you become affected. In 75% of the time, you either get both good copies or a single bad copy. And if you only get one single bad copy, the good copy is fine in terms of maintaining normal health. So this is a recessive disease, meaning that both genes from both parents have a spelling mistake. It's what we call a mutation. In other diseases, unfortunately, if you only get one bad copy from one of your parents, even though you have the good copy from the other parent, the bad copy takes over and it's sufficient to cause disease. So this is called a dominant mode of inheritance. And in this case, if you have one affected parent and one unaffected parent, then the chance of a child being affected is 50%. Initially, when people were looking at the genetics of Wolfram syndrome, they found out that in families who had a recessive form of Wolfram syndrome, they found these spelling mistakes, these mutations in a gene known as WFS1. And it's a lot of work has been done into this, and obviously this is a simplification, but the wolframin protein is located in the endoplasmic reticulum. And the reason why this is quite relevant to me, because of my personal interest in mitochondrial genetics, is we do know that there's a very close interaction between the endoplasmic reticulum and the mitochondria. And the reason why this is relevant is because for some of you who are not aware of this, in every single cell of the human body, except for some very rare exceptions, we have a lot of these mitochondria, which are in effect the batteries that power the cell by producing all the energy that you need for normal health and normal survival. And if you have a problem with these mitochondria, you don't produce enough energy, and at some point, this tips the balance over, and this results in a cell not working properly. And if things are bad enough, then the cell will die and you can't bring it back to life. As I've mentioned already, you're born with roughly around 1.2 million of these retinal ganglion cells, and the outstretching, the axons, converge to form the optic nerve. So this is an area of intense interest. Different groups are looking at different areas, but nevertheless, it is quite a complex process. So many things can contribute and work together to ultimately make you lose your retinal ganglion cells. But one of the things which people have been looking at very carefully in the context of visual loss in Wolfram syndrome is the so-called interactions between the endoplasmic reticulum and the mitochondria. So coming back to Wolfram syndrome, most patients will have a spelling mistake in both copies of the WFS1 gene. So it's a recessive form of disease, meaning that both mom and dad do not have any problems because they have one good copy and one bad copy. But unfortunately, if they have a child who have two bad copies, it results in Wolfram syndrome. But now, it's becoming increasingly apparent that in some cases of Wolfram-like syndrome or WFSN or WFS1 spectrum disease, some people can develop some of the features of Wolfram syndrome when they have a spelling mistake in only one bad copy of the gene. So it's a dominant form of Wolfram syndrome. So in effect, we have recessive and dominant. Both of them can cause visual loss, but the severity of the disease can vary. So when I see people coming to see me in clinic, either for the first time or they're coming back for their annual review, the obvious question is, what will happen in terms of their visual loss? Will it get worse? Will they go completely blind? What can they do to try and stabilize their vision? So we've been very fortunate to have access to a large database of people with various forms of genetic eye diseases, including Wolfram syndrome, which is what got me interested in this field around 10 years ago. So we were able to put together a large group of people with dominant WFS1 mutations. And what was quite clear to us is that patients with dominant forms of the disease had a much less severe form of the disease. So they were not as severely affected as people with recessive Wolfram syndrome. Very often, people develop visual problems either on its own or in combination with hearing loss. And which is good, there was no other significant defects, for example, peripheral nerve problem, balance problems, or bladder problems. And we looked into that a bit more carefully, and we've put together a group of people, so 37 patients with confirmed mutations in this WFS1 gene. And out of these, 18 patients had recessive mutations, both copies were defective, and 19 patients had dominant mutation, meaning only one copy was defective. And optic atrophy was diagnosed at the average age of 15 years, but as you can see, it ranged from 3 years old to 60 years old. The reason why some people are diagnosed much later is either because they have a mild form of the disease and therefore they are not aware of any problem until much later on in life, or they've been detected because someone else in the family has been diagnosed with Wolfram syndrome and they've come to see us for screening and genetic counseling. So this is what you will normally have in your clinic. People will be checking your vision using these charts. And then very often there will be someone else who will be checking whether or not you need glasses to try and optimize your vision. And then after you've had your vision checked, various things will get done. You will have your eyes dilated very often to have a much better view of the back of the eye. You can see me here looking at someone's eye using what we call a slit lamp microscope because it gives a very good view, a very good direct view of the back of the retina. And then what is good now is that we can take pictures of the back of the eye and then we can store this. And it's very helpful because we can compare things, many years down the line, or we can send these pictures to other clinicians in other parts of the country or other parts of the world. So when we look at the 18 patients who had recessive mutations, the average vision was 6/36. So what does that mean? If you can make out the top letter in the chart, this is 660 vision. So on average, people had reduced vision and they could only make out the top letters on the vision chart. If you look at the 19 patients with dominant mutations, vision was much better. The average vision was 612, meaning that you could make out the much smaller lines, not complete at the bottom, but certainly good enough. And 612 is not bad because this is on the borderline of whether or not someone can drive in this country. So I think the important conclusion is that patients with dominant WFS1 mutations tend to have better vision, and this is in keeping with our own clinical experience. Now, the next stage is to try and look at a much larger sample of patients and then look at all their visits over time, because this gives us a lot of information about how the disease is progressing. So for those of you who can make out the graph, which I'm showing here on the screen, on the x-axis, you have 0, 20, 40, 60, and 80, which is the age at which the vision was checked. And for every single line, this is one person, right? So you can see how some people have been followed up for quite a long time, 10 years or more. On the y-axis, you can see the change in vision from 0 to 1 to 2. And as the number is getting more, vision is getting worse. So you can see that for most people in our cohort seen in the UK, vision is getting worse over time, but at different rates. So when you combine all this data together, you get these two thicker lines, the thicker red line and the thicker green line. And the thicker red line are patients with dominant mutations, one single copy. And the thicker green line are patients with recessive disease, meaning two bad copies. And again, you can see here that the group with recessive mutations lose vision at a much faster rate compared with patients with dominant mutations. The other thing that we can do is we can measure someone's field of vision. And some of you in the audience will have already done, either because you're going to see the doctors at the eye hospital or because your optician has this as part of your routine check. And we check one eye at a time because this gives us much more useful information. And here you can see 3 different time points, and you can see how vision is getting worse. On the left, you can see there are a few spots which are being missed in the periphery. But then as the retinal ganglion cells are lost and as the optic nerve gets more and more damaged, the dark areas start to expand. And then finally, if it involves your central part of your visual field, that will make your vision drop quite quickly. And I'll just give you a brief summary for the benefit of time. But all this information was published at the end of last year in the American Journal of Ophthalmology. And we're very fortunate to have a large group of clinicians in the UK who contributed patients and data for this. So this was a very useful study for us because not only did it allow us to get a much better feel of how disease is progressing in Wolfram syndrome, but it also allowed us to extend our network, which is going to be very helpful and has been very helpful already for the Treat Wolfram trial. There are a lot of things that we do. I won't go into this in great detail, but we can also use various retinal imaging techniques where we can take very high resolution pictures of the back of the eye, of the retina, and of the optic nerve to look at the different type of cells in your retina. And the good thing about this, it's non-invasive, it's very quick, it's very safe, and most people do it very easily. And you get these very high resolution pictures of the back of the eye, and then you can measure the thickness of the nerve, you can measure the thickness of various parts of the retina. And we always do this in the genetics clinic when people come to see us, including people with Wolfram syndrome. And it's very useful for us because by being able to measure the thickness of various layers, it tells us whether things are changing over time. And we did that in our group of people that we've seen in Cambridge and Morpheus Eye Hospital. And without any big surprise, as the disease progresses, as vision is being lost, you get thinning of the retina and you get thinning of the optic nerves. And again, what we showed here very clearly is that if we measure the thickness of the retina and the optic nerve, people with recessive mutations, meaning two bad copies, had much greater thinning. And that's the reason why vision got worse more quickly. And, and people end up having more trouble, with their eyesight. The other thing which I will mention here out of interest, but also because it might be relevant in terms of understanding how the disease affects the eye, when we look at the pictures of the retina, we sometimes saw this rather strange little line, this kind of defect. And we don't see that in a lot of other diseases. And in the context of Wolfram syndrome, what is very interesting is that we only see this line in patients with dominant disease. And so far, we've not seen that in any patient with recessive disease. The problem is, what does it mean? It probably only tells us that there are differences in terms of how the optic nerve gets damaged depending on which types of mutation that you have. And this has a relevance in terms of the way that these cells are being lost and some of these changes that we're seeing on retinal imaging. So it's a useful information because sometimes if I see someone coming in clinic with visual loss, with optic nerve problem, and they have this so-called lamination defect, straight away I think about WFS1 and I think about Wolfram syndrome. So these are just different examples from different people that we've seen in clinic before. The last thing which I'm going to mention, because we also do this, is now we have very good technology which allows us to look at different parts of the visual system from the eye to the back of the brain. And the reason why this is relevant for us, as I've mentioned already before, it's a network. The eye produces a signal, the brain does all the processing, but in between you have the optic nerve. And what we can do with visual electrophysiology, which is the technique that we use, it allows us to assess, measure, and determine how quickly the electrical signal is being sent from the eye to the brain. So this is just one setup here. And I think the one thing to mention is that we can do that in very young children. Very often, it's not a problem because the technicians will turn this into a little game. And it's just electrodes around the eye and around the forehead. So nothing is being stuck and nothing is too painful. And you get all kinds of these signals being transmitted. It can be like a checkerboard. It can be like little lozenges. But the reason that we do this is, again, just to test the eye in different conditions, in bright conditions, in dark conditions, and with different types of signal. And what we measure the speed at which the signal is being sent and also the strength of the signal. And this can give us very good information about which part of the eye is affected, especially the optic nerve. So in Wolfram syndrome, again, when we've looked at the measurements, without any big surprise, there is a delay in how quickly the signal goes from the eye to the brain, and the signal is not as strong. And the reason why we collect all this type of information is because in due course, this could be helpful in terms of knowing whether or not a new treatment is working. Because if, for example, a new treatment is working and you're able to save these retinal ganglion cells and the optic nerve is working better, then obviously the signal will be stronger and will be sent at a much faster rate. So this was just an overview of what we know about the mechanisms which lead to vision being lost in Wolfram syndrome. But obviously, there's a lot that we still do not yet understand. And that's the reason why sometimes there can be delays in terms of coming up with new treatment. So in Cambridge, we're quite fortunate to have a dedicated space for the clinical vision lab, which allows us to see people with various genetic eye diseases. And this is also helping with various clinical trials, including gene therapy trials being run in Cambridge. And the reason for that we set this up about 3 years ago is because I think all of us are very aware of the challenges of doing clinical trials for rare disease. A lot of work, a lot of effort, a lot of money goes into doing all the basic science work in the lab to determine, how are the cells being lost, what treatment could potentially work. But ultimately, when you have your top choice of a potential treatment, whether it's a drug, whether it's gene therapy, whether in the future stem cells, you have to test it in clinical practice, and you have to do it, first of all, in a small group of patients, what we call phase 1 studies, to know whether it's safe. And then you have to do a large study, which is a phase 3 study. And, although we all want this cure at the end, you have this very long journey from the lab to the clinical trials, and someone has to pay for it. And the amount of money you need to run these clinical trials is pretty mind-boggling. And that's the reason why progress has been a bit slow for various rare diseases, because there's been a lack of funding to move this from the bench into the bedside, as people would say. And if we're going to be investing all that time and all that effort into running clinical trials, we need to be sure that when we run these clinical trials, we have the best possible design and we have the best possible ways of detecting whether the treatment is working or not working. Because, otherwise, it would serve no purpose, because in the end, we would not have a clear answer about the potential treatment. And that's the kind of thinking behind this facility in Cambridge, because we have realized that to be able to run these advanced therapies, we needed a space within the clinical research center where we could bring people in to run various tests that we normally do in clinic, but also tests that we do not do in clinic, but that could be helpful in the future. So, you can read more about the work that we're doing in Cambridge. We have a website on the university website called MitoCam, which brings together a number of clinicians, neurologists, ophthalmologists, pediatricians, and also basic scientists who are interested in mitochondrial disease and genetic eye diseases. So, I work very closely with a number of people, including the neurology team. And now that the Vision Lab has been running for nearly 3 years, we have a number of studies running, from eye studies to brain studies, and also rarer conditions affecting the brain in later years. So these are the equipment that we have there, including the things that we don't normally do in clinic, like measuring how quickly the images are being sent from various parts of the retina to the eye. And also something that we're looking into more carefully, which is a new form of imaging technology that allows us to look at the retina and allows us, in theory, to look at how well the mitochondria are working. So this is still early days, but it is a very easy test for us to do. It's quick, it's painless. It just uses a special source of light to scan the retina, and then it gives us an indication of how well the retina is working and how well the mitochondria are working. And we've the usual group of friends and collaborators in London, Cambridge, and Birmingham. We are now recruiting patients into the Orion study, and that includes patients with Wolfram syndrome. And by running all these tests, on a yearly basis, we hope that we'll be able to detect ways of checking how the disease is progressing, and then potentially in the future, these could be included into clinical trials. So I think just to wrap up before the question and answer session, optic atrophy is an important defining feature of Wolfram syndrome because visual loss is something which can be quite scary and something which is which a lot of people have concerns about for obvious reasons. We do know that vision gets worse much more quickly in patients with recessive WFS1 mutation, as I've shown already, in terms of how more quickly the vision gets worse. Why that is the case is something that we need to look at into more carefully. A lot of new technology are being introduced now in ophthalmology, including new imaging technology that potentially will help us better understand how the disease progresses over time. And then you will have heard updates from Tim. I know that Fumi will be giving a talk as well on some of the exciting work coming from his lab. But visual loss is multifactorial. There are a lot of things which are contributing to the optic nerve not working properly. And my personal view is that we will probably need a combination of different strategies. So thank you very much for your time, and very happy to take questions from the audience. I have one question here. Does vision deteriorate until we are blind, or does it stop at some point? That's a very good question, and that's something which I get asked very often. We have 1.2 million of these retinal ganglion cells, and very often in the early stages, you lose these retinal ganglion cells in the central macula. And that's the reason why vision drops, i.e., how well you can see down the vision chart. Fortunately, the retinal ganglion cells in the other parts of the retina tend to be much more resilient. So most people with Wolfram syndrome will lose a lot of their central vision, but they tend not to lose their peripheral vision in the long term, meaning that you're able to navigate and it prevents you from bumping into things. Of course, there can be some very rare exceptions where people are very severely affected and they end up only being able to perceive light and dark. But in my experience, this tends to be a much rarer situation. So I do tend to tell people that their central vision will be affected, unfortunately, which is quite disabling because you're not able to see people's faces, you cannot see the numbers on the bus, but most people preserve. There's a second question here. How much credit should we give to what we read on the internet about pills and zebrafish packs that can restore 20/20 vision? I must say I'm not familiar with this. What are these pills derived from zebrafish, or can I have a bit more information about this? Having said that, I know that I don't know the specifics of it, but various types of combination of vitamins and antioxidants have been put forward for various genetic eye diseases, and the evidence is very slim. I think the important thing is to discuss with your clinician, carefully, just to make sure that you're not getting something being bought from the internet that could potentially be harmful.
Thank you, Patrick.